The scientific agenda for the 2025 NEI Spring Congress will cover everything from traditional medications to what's new on the market now, filling any gaps in your education as well as new developments. Register now for our popular spring event being held May 8th through the 10th in person in the city of brotherly love, Philadelphia, which is also the city where I was born and raised, my beloved hometown, and via simulcast online. Secure your spot today at nei.global/SP Congress 25A. That is nei.global/SP Congress 25A.
Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. I'm your host, Dr. Andy Cutler, and with me today, I'm very excited, is Dr. Jennifer Payne. She is a psychiatrist specializing in reproductive psychiatry and mood disorders, and she serves as Vice Chair of Research and Professor in the Department of Psychiatry and Neurobehavioral Sciences at my beloved University of Virginia. And she directs the Reproductive Psychiatry Research Program. For those of you who don't know, I did med school and all my training, including research training and residency there. And so we've been having a nice little conversation about UVA. But Jennifer, how are you?
I'm great. Thank you for having me today.
Yeah, I'm real excited because I don't know that we get enough training in this area, and it's certainly a very important area. We are seeing more and more women, especially women of childbearing age. Depression, unfortunately, is on the rise, as you know. So, this term reproductive psychiatry, it could mean many different things. So how would you describe reproductive psychiatry, and what should we know about it?
Sure. So I first used the term back in 2009. I wrote a review for the Harvard Review of Psychiatry in which I talked about reproductive depressions. And in that review, I talked about depressive episodes that are specifically triggered by times of reproductive hormonal change in women. So postpartum depression is a great example. But of course, there's premenstrual dysphoric disorder and perimenopausal depression. And reproductive psychiatry is really the study of those types of depressive or mood episodes that are triggered by hormonal change. The reason why I think they're both clinically and research-wise significant is that they're likely a subtype of major depression more globally. And we see them very commonly in women, and they really, from a clinical perspective, have some very specific approaches to managing them.
Yeah, I would imagine at different phases of a woman's life, you're going to do things a little differently. And I've always been fascinated, Jennifer, the brain's loaded with hormone receptors, but we don't have a lot of treatments that seem to target that, maybe indirectly, but that's always been interesting to me. We haven't taken advantage of that more.
Well, I agree with you. I think it's because it's a pretty complicated system, and we are still trying to figure out exactly what's going on in a woman's brain across the menstrual cycle and across her reproductive life. And so I think we basically just don't have the knowledge to target those receptors yet.
Sure. Well, I want to start out, why don't we start out with pregnancy? And obviously, there's a couple of different areas that are very important for us as clinicians. But let's start out with, how does maternal mental health impact fetal and infant development?
Absolutely. So, and thanks for asking that, because most people miss that really important point, which is that when mom is not psychiatrically stable during pregnancy, that has negative outcomes, not just for her, but for the pregnancy as well as the exposed developing child. So we know that when mom's seriously depressed in pregnancy, that she's more likely to have a C-section, preterm birth, and that baby's likely to have low birth weight. We also know that when babies are born to mothers who've been depressed during pregnancy, they have elevated cortisol levels. And those cortisol levels last till at least adolescence. That's as far as we've looked. And so that may actually be that first hit of vulnerability to the development of psychiatric disorders. In addition, when mom is depressed during pregnancy, she is very likely to be depressed postpartum. And postpartum depression has clear and significant effects on language development, IQ, and behavioral and psychological problems in the exposed children.
Yes. So it sounds like there's both biologic mechanisms at play and, of course, environmental. If a mom's depressed, she's not bonding as well with the child and so on.
Right. Exactly. And, maternal, any psychiatric illness in the family is considered an adverse childhood event. So it's really critical to identify women who are suffering either during pregnancy or postpartum with psychiatric illness and get them treated. Again, not just for mom, but for the exposed child.
Yeah, so I can imagine a child is genetically vulnerable. Obviously, if the mom's had depression, they're genetically vulnerable. And then this elevated cortisol, we know, sets you up for depression pretty much the rest of your life.
Exactly. And, there have been a lot of studies. We know that that depression runs in families, but we've not been able to identify, a gene or genes that leads to major depression. I think this may be one way that we transmit it from generation to generation, is that babies born with elevated cortisol levels are going to be more susceptible.
Yeah, I was not aware of that link you said between maternal mental health and pregnancy complications. That's interesting. So, yeah.
Yeah, well, if you think about it, it makes sense. When mom's depressed and she's pregnant, she's dumping cortisol. And that's going to make it more likely that she'll give birth early, and the baby will have a lower birth weight. And it just increases the risk for all kinds of complications, including preeclampsia and C-section.
Yeah. Well, I'd like to talk about treating the depression while the mom is pregnant, and then maybe we'll talk about the postpartum period.
Sure.
Obviously, a question I get asked all the time is about what medicines are safe in pregnancy, and can I use X, Y, or Z during pregnancy? So what are some of the considerations about psychotropic meds during pregnancy? Are there any that are safer?
So I don't like the term safe or safer. It's really about risks and benefits. And most people think about the risks of taking a psychiatric medication during pregnancy, but they don't think about the risks of not treating maternal psychiatric illness in pregnancy, right? And so it's really a risk discussion. And there's a robust literature showing that untreated psychiatric illness in pregnancy isn't good for pregnancy outcomes or infant outcomes. So the reality is you can take almost any psychiatric medication during pregnancy, with the exception of two medications that should generally not be used during pregnancy, and that's valproic acid and carbamazepine. And everything else is really about what do we know, and is it working? Right. So we try to use older medications that we know more about. So, for example, we know a lot more about fluoxetine than we do than some of the newer antidepressants. And that being said, if a woman does not respond to fluoxetine, it does not make sense to switch her to fluoxetine, right? It also doesn't make sense to switch a woman from a medication that's working to an older medication if she's just found out she's pregnant, okay? The baby's already exposed, and by the time you figure out that someone's pregnant, most of the organ formation has happened, okay? Sometimes people want to switch at that point, but then you're just exposing the baby to the original medication, the new medication, and potential maternal psychiatric relapse. So that's 3 exposures. So So if you're going to switch medications, do it before she gets pregnant.
I see. Now, you made such an important point. This is a point I've been making for a while, and that is when we talk about risk, we talk about often side effects of medicine, or in this case, maybe teratogenicity, but we forget about the risk of inadequately treating the illness. So I love that you made that point, and that has to be balanced out. My understanding is SSRIs generally have lower risk during pregnancy. There's been some meta-analyses and things, and even atypical antipsychotics have turned out to not be as bad as we might have thought. Is that fair to say?
Correct. There are a couple of studies that have shown that babies exposed to atypical antipsychotics have just slight developmental delay at 6 months that goes away by 12 months. But unfortunately, those studies did not control for confounding by indication. And what that means is that they didn't control for the fact that those mothers were taking those medications for a mental illness. So they didn't control for severity of the mental illness. And so that slight developmental delay, it's unclear if it's due to the medication or to the fact that their mother had a psychiatric illness. We also don't know we know that they didn't control for psychiatric symptoms during pregnancy. So just taking a medication during pregnancy does not guarantee that that mother is well during pregnancy, right? So the studies are hard to interpret sometimes, but basically atypical antipsychotic data has been generally reassuring.
Okay. Now, I want to go back to the anticonvulsants. Of course, you mentioned valproic acid, which in my opinion should be avoided in women of reproductive age anyway.
I think that's right. I don't forbid it, though. I think it's there are some countries that have said that you cannot use valproic acid in a woman of reproductive age for bipolar disorder. And I don't think that that's appropriate. I think if we can use it for seizure disorder in a woman of reproductive age, we should be able to use it for bipolar disorder. But it's really a medication of last resort, in my opinion.
Yeah, actually, Europe has put significant restrictions. There was a newer study I'm sure you're familiar with that children born to mothers on valproic acid had a much higher incidence of neurodevelopmental issues. And even children born to fathers who were taking valproic acid. My friend Jonathan Meyer taught me this. And so I think we've got other options is kind of how I look at it. We've got a lot of newer options.
Absolutely.
I want to consider, yeah. Of course, now, speaking of Jonathan Meyer, he just wrote the Lithium Handbook. So, of course, I have to ask you about lithium, which when I was training was taught to be a big no-no during pregnancy.
Right. It is no longer considered a no-no during pregnancy, at least by those of us in reproductive psychiatry. I'm positive you can still find some psychiatrists who will say it's a no-no. But it was a no-no because it's been associated with a cardiac defect called Epstein's anomaly, right? And the original study showed a pretty high rate of that. But some really good researchers went back and looked at all pregnancies exposed to lithium and found that less than 1% developed that organ malformation with exposure to lithium. Now, what's interesting is if you take women who are lithium responders and you stop their lithium for pregnancy, there have been a couple studies on the relapse rate, and it's 80 to 100%.
Oh, my goodness. Yeah, not good.
Right. So you can guarantee that a woman can relapse if you stop her lithium, and it's less than 1% of babies are born with a cardiac defect that is surgically correctable.
Okay. Yeah, that's really helpful to balance that out. Lithium also has some anti-suicidal properties, and it's been shown if you stop lithium, you can get a kickback or an increase in the risk of suicide, which is obviously horrible here, too.
Agreed. And, the most common cause of maternal mortality in the United States today are psychiatric in nature.
Oh, I was not aware of that.
Yeah. So about a third of maternal deaths are either suicide or overdose.
Oh, my goodness. That's really important. Thank you for sharing that with us.
Yeah.
manage the medications differently through the different trimesters of pregnancy? And of course, you mentioned by the time a woman is aware she's pregnant, usually they've gotten through the first trimester.
Yes. So what we know is that a woman's blood volume doubles in the course of pregnancy, okay? And her metabolism of drugs changes with the changing hormone levels. And so a lot of women will relapse with their psychiatric illness in that third trimester. Currently, we don't follow particular protocols to automatically increase doses, et cetera. As a reproductive psychiatrist, I follow women very closely in that third trimester and have a low threshold for increasing doses of psychiatric medications. If it's a medication where we can monitor blood levels, I do that. And I prophylactically increase medications that we can measure blood levels for if their blood level drops. Lamictal is kind of a special case, or lamotrigine. Estrogen chews up lamotrigine, and so as pregnancy progresses, it's very likely to drop its blood level and may even become non-detectable. And neurologists have been following blood levels on a monthly basis in the second and third trimesters for years and prophylactically increasing Lamictal. I just finished a study looking at doing that for women with bipolar disorder. I don't have the results yet, so stay tuned. But clinically, I do this very commonly, that I follow Lamictal levels and prophylactically increase Lamictal to try to prevent relapse.
How high would you go? I mean, say a woman's on 200 milligrams. Are you talking 400, 600?
Yes.
How high? You have whatever it takes. Right?
Yes. I mean, and what we do is once she delivers, we go back to the pre-pregnancy dosing.
Okay. Yeah, it makes sense. How do we counsel women about their psychiatric illness and about their medications if they're planning to get pregnant?
Yeah, so I think it's important whenever you're prescribing a psychiatric medication to a woman of childbearing age to talk to her about whether or not that particular medication would be what she would want to be on for a pregnancy. So 50% of pregnancies are still unplanned in the United States today. So if you're a psychiatrist and you haven't had an unplanned pregnancy in your practice, you're due one or two. And they occur in women who are using contraception. So in my practice, I've had a copper IUD pregnancy, a birth control pregnancy, and a status post vasectomy pregnancy.
Yeah, I've seen those, yeah.
Right?
Yeah.
So you can't rest easy thinking that they're taking contraception. So it's an ongoing conversation in my practice. We talk about what would happen if there was an unplanned pregnancy. And I always emphasize that it's better to plan a pregnancy and that we know what you're going to be taking during pregnancy from the get-go.
Yeah. But this, of course, that statistic you just said of half of them being unplanned makes me think maybe we should be prophylactically thinking about our medication choices in women of childbearing potential, because there's a very good possibility they'll get pregnant. So maybe we should be thinking about some of these things.
Absolutely. Yeah. I do think it's a balance. I mean, I certainly think about it because this is, my bread and butter, I'd say. But, we also want to get women well, right? And so I wouldn't, for example, not prescribe a second or a third psychiatric medication in someone who's really struggling to get well, because we'd prefer to be on fewer medications for pregnancy, for example. So we want to get women well. But I think having an ongoing conversation is the best way to make sure everybody's on the same page for a pregnancy.
Yes. Yeah, we talk about shared decision-making, and of course, that's what you're talking about, of course.
Exactly.
And taking the woman's preferences and understanding her history, as you said, if somebody has not done well with a medicine previously, of course, you would not use that medicine.
Right.
So that makes sense. One of the things we didn't talk about, we talked about the risks while the woman's pregnant, but of course the atypical antipsychotics have warnings about the infant going into withdrawal. And so what are the issues with withdrawal when the baby is born?
So it's interesting because we don't actually know that it's withdrawal. This was a big topic about antidepressants a number of years ago. And basically the syndrome is called Poor Neonatal Adaptation Syndrome, or PNAS. And about a third of babies exposed to antidepressants will have PNAS, and about a third of babies exposed to atypicals will have PNAS. And it's a syndrome that it's a spectrum of symptoms. It can be very mild, and it can be more severe, requiring a NICU admission, and even we can occasionally see seizures. But the typical syndrome is the baby will appear shaky, will be kind of difficult to comfort, and may have tachypnea and tachycardia, may have some loose bowels, etc. It's a short-lived syndrome, and typically passes within, if not a few hours, a few days. And we don't think that there are long-term repercussions from it generally. It's interesting that it's the same percentage in both antidepressants and atypicals. And there's one study that really associated the syndrome with having a particular polymorphism and a particular gene having to do with serotonin metabolism. So it may be more about a genetic makeup in response to medication rather than a true withdrawal syndrome.
Okay, that makes sense. I can just imagine, though, an infant who's exposed to the maternal blood supply and is getting this concentration of medicines and then suddenly is delivered and is no longer. And I would think some of them are worse than others. I mean, we think of paroxetine and venlafaxine in particular as having really bad withdrawal syndromes in adults. And I can imagine the same would be true for the infant. So maybe we should think about that as well in choosing a medicine. Maybe paroxetine and venlafaxine are a little riskier?
Well, we need to do that study. As a researcher, I have actually thought about doing that study and really trying to nail that particular question down. We also haven't done the study of whether we see the syndrome less in breastfed infants, because that would be a withdrawal, if you would, a step down from the dose received in utero. Interestingly, one of the earliest studies looking at PNAS, a majority of those babies were exposed to paroxetine. And so we are all suspicious that, as you are, and so I think that's a really good thought. But honestly, this is an area that needs to be studied in more detail.
Yeah. Yeah, I mean, we sometimes talk about these classes of medicines like SSRIs, atypical antipsychotics, but the medications really vary in their pharmacokinetics and pharmacodynamics, and so I can't imagine they'd all be the same. It doesn't make sense to me somehow.
I completely agree with you. And if anybody out there is looking for a research topic, please consider this one.
That's a good one. Yeah. Okay. Now, let's talk about what we do in the postpartum period. So let's say a woman has not really been depressed during the pregnancy, but now has a postpartum depression.
Right.
So what are the considerations there?
So it's all about who that woman is and what her history is, right? So is she on meds? Is she off meds? Has she been on medications prior to pregnancy that worked for her? Is this her first episode of depression or not? If it's a first episode of depression, we tend to use SSRIs. There's also a new FDA-approved medication, zuranolone, which has a very unique mechanism of action that can be used. And it has some advantages over SSRIs. But really, SSRIs have been the mainstay of first episode postpartum depression for a long time. But if a woman has a history of major depression and has responded to a particular medication or class of medications, we definitely go back to that and use that in the setting of postpartum depression.
Yeah. Yeah, zuranolone, as you mentioned, is considered a neurosteroid, which is very interesting, and works partly, we think, through GABA-A agonism, or partial allosteric modulation, I should say. But it is very interesting, and there's all kinds of evidence that kind of mechanistically makes sense.
Yeah, it's really a wonderful new addition to our repertoire, if you will. It has a very high response rate, a very rapid response rate, and it's a medication that is given only for 2 weeks at a time. And so it's kind of perfect for that first onset of a depressive episode postpartum, because you're not saying you have to take this for at least a year, or maybe, longer. And so it's very attractive to women for that reason.
Yeah, it really makes sense because you're talking about an acute perturbation, if you will. So giving that 2-week course, in my mind, is somehow restoring a balance, or is, treating the problem. And you're right that there's evidence of long-term benefit even after just a 2-week course.
Correct.
So that's certainly good.
So I just published a paper that demonstrated that there were changes in the neuroactive steroid pathway in women during pregnancy prior to developing a postpartum depression. And so we think that women that develop postpartum depression may do so in the setting of those rapid hormonal changes that occur at delivery. But I have evidence that there's already a vulnerability in their neuroactive steroid pathway prior to delivery. And so those two things together likely trigger a depressive episode in vulnerable women.
Yeah. Now, I need to get your opinion on something else. I always talk about especially severe or psychotic postpartum depression is highly suggestive of bipolar disorder. Now, am I overcalling that? What's the literature on that?
So if you're using the term postpartum depression, yes. If you're using the term postpartum psychosis, no. So postpartum psychosis is absolutely bipolar disorder until otherwise proven. And the appropriate treatment for it is lithium plus an atypical antipsychotic. The literature is very clear. I will tell you that women who have postpartum depression are at slightly higher risk of developing bipolar disorder over the course of their lifetime. That doesn't mean that you treat them for bipolar disorder, because a majority of them do not. They go on to have major depressive episodes. But there is something about that postpartum time period that is vulnerable to bipolar disorder.
Yeah, so I guess what that means is we need to really monitor closely. And if you see, particularly with an SSRI or traditional antidepressant, it's either not working or they're getting worse, that's always a clue to bipolar. A friend of mine, Sloan Manning, calls it antidepressant misadventures, which I love that term.
That's a great term.
Isn't that great?
Yeah.
Another risk factor for bipolar, interestingly, is if your first lifetime episode of depression is before the age of 25, that actually triples the odds you're bipolar, and you might be interested. That comes from your old alma mater, from Barbara Geller and colleagues at WashU in St. Louis. Did some incredible studies on that. Sadly, she passed away not that long ago.
Yes.
But she did a lot of great work.
That's a great statistic, and it's absolutely something to keep in mind when you're following patients over the long run.
Yeah. So I guess my point is that if you have a woman who had a previous episode of depression when she was younger, and now she has a bad postpartum, I guess my antenna would be up for bipolar. I'm not saying, like you said, it's not definitely bipolar, but boy, it raises the odds. So I think that's an important point. Yeah. Because obviously the treatment is different from unipolar MDD.
Yeah, that case might be a case where you talk to the family members and you educate them about bipolar disorder and what that might look like. Because if you're giving an antidepressant in that setting, you might trigger a manic or a mixed episode, and it would be great if the family were clued in ahead of time.
Right. I always think about that really sad case of Andrea Yates in Houston, the woman who had 5 successive psychotic postpartum depressions, and I have a personal connection. The cover of Newsweek magazine said schizophrenia with her picture on it, and she was clearly not she clearly did not have schizophrenia. She worked as a nurse. She was high functioning, and she had bipolar disorder quite clearly.
Absolutely.
So that's a very sad situation with the consequences of inadequately treating a severe postpartum depression.
Agreed.
She killed her 5 kids.
Yes, that was a terrible case.
And interestingly, Jennifer, I don't know if you know the backstory, her psychiatrist had stopped her medication or antipsychotic before this happened. I'm sure it was somewhat well-meaning, but boy, with that history, I'd be very careful.
Well, we see all kinds of things in reproductive psychiatry. A lot of doctors will stop psychiatric medications for pregnancy, and really, I don't believe that is standard of care at this point. We really need to be actively managing psychiatric illness during pregnancy and postpartum.
Yeah, I totally agree. I mean, that's so important. What other things besides medication? I mean, I always believe the best outcomes are a combination of medicine and other things. Obviously therapy, lifestyle interventions, yoga, exercise, whatever. What kinds of things do you recommend in addition to medicine?
Well, everything you just said. Psychotherapy is obviously a great thing to recommend. It is often difficult for moms with young kids to participate in psychotherapy. And there are whole, portions of the population that really cannot do that. They can't afford it, et cetera. But I absolutely recommend family support, and prepping, if at all possible, during pregnancy for the postpartum time period. Making sure that you have support, freezing dinners ahead of time.
Oh, that's good. Yeah.
Right?
Yeah.
And just being really prepared to welcome a new child into the world, but also to make sure that mom has the support that she needs. There are a lot of mom groups that you can join while you're pregnant, and I recommend doing that. And really just making sure that mom has permission to take care of herself, and make sure that those supports are in place.
Yeah. I'm a big fan of peer support, so I love that idea of the mom support group. I do want to talk about, of course, premenstrual and menopause, but one other thing. What recommendations do you have? How's the best way to work with, obstetricians and pediatricians? Because, what I found being a parent, and in our case, it was funny, this transition. It was the obstetrician up until birth, and then all of a sudden we're going to the pediatrician. The obstetrician wasn't involved anymore. So how do you recommend working with them?
So when I teach about this, I always recommend that the psychiatrist take the role of the quarterback.
Okay.
And you're right. And I mean, we are supposed to be experts in communication, and that's plus or minus, or some. But the psychiatrist should reach out and talk to the OB-GYN, explain what the plan is and why the plan is being implemented the way it is. A lot of obstetricians don't know that you can take psychiatric medications during pregnancy. And so it's I think that makes it even more important that the psychiatrist be the one to do the communicating. And then I think it's the same with the pediatrician. Mom might be breastfeeding on a psychiatric medication, and what you don't want is for her to get a different message from the pediatrician compared to what the psychiatrist is saying. And so it's important that the psychiatrist talk to everybody involved, including the mother-in-law if necessary.
Very good point. Yeah, certainly I know how my mom was involved. It's interesting. You just made me think of something, because in the past, when I have referred patients to a neurologist, they have stopped their medications. And the same thing, I guess, with obstetricians and pediatricians being well-meaning, but, they're not as well trained to understand the risks of doing that necessarily. So I think that's a really good point.
I've never understood that. I would never stop blood pressure medicine.
Yeah, exactly.
Right? I would call the doctor and say, I think this blood pressure medicine's contributing to this patient's depression. Let's talk about it. But I would never presume to stop another doctor's medication.
Of course. Yeah, it's funny how psychiatry sort of gets short shrift, if you will. Or
I agree. It's the
kinda-
stigma.
Yeah, the stigma, I'm sure that's true. Okay, let's now go back and let's talk about premenstrual depression.
Premenstrual symptoms or premenstrual dysphoric disorder. So
That's right.
I really think about premenstrual mood problems as kind of three categories. There's PMS, which is a premenstrual syndrome or premenstrual symptoms, which a majority of women experience at some point in their life. And these are mild, typically mood symptoms, but they may also have physical symptoms that occur during the luteal or the premenstrual phase of the menstrual cycle. And some estimates are as high as 80% of women will have some symptomatology. And the important point is that those symptoms don't impact their functioning. So they go to work, they may get into a fight with their husband, but they get into the fight with their husband when they're not premenstrual as well. So it's not really impacting their functioning. And women whose symptoms are severe enough that it impacts their functioning, they get a diagnosis of premenstrual dysphoric disorder, and it really needs active treatment in order for them to function on a regular basis. And then I also think of something that really isn't well described in the literature, but most of us who are psychiatrists have observed it over and over, which is premenstrual exacerbation. So this is what we see in women with psychiatric disorders, that the psychiatric disorder kind of relapses or gets worse in the premenstrual time period. And you can see this in schizophrenia, and you can see it in major depression, and you can certainly see it in bipolar disorder.
Yes, I have seen that. So would you recommend then at that point in the cycle to increase medication? If this, assuming they're on a medication already?
So it depends on the psychiatric diagnosis. So for women with schizophrenia or schizoaffective disorder, I often get them on birth control pills that they take continuously, because that drop in estrogen really can cause pretty significant cognitive symptoms as well as mood symptoms. But you can use an SSRI during the luteal phase of the menstrual cycle for those women as well. And women with major depression, if they're on an SSRI, I tend to bump the dose of that SSRI. And women with bipolar disorder are a little trickier, because adding an antidepressant in the luteal phase might trigger cycling for them. I have had women with bipolar disorder for whom we give a little SSRI in the luteal phase. But hormonal options for them may be a little bit safer, depending on their medical history.
Well, of course, the effective treatments for bipolar depression are atypical antipsychotics, so I guess you could increase the dose of that a little bit too.
I have not had that work as effectively as SSRI. So we know that the premenstrual symptoms really do have to do with serotonin levels. And this is what's cool from a biology perspective. You can dose them just during the luteal phase. So a woman can wake up, realize she's having premenstrual symptoms, pop a Prozac or a Zoloft, and feel better in hours. Okay, so it's a totally different mechanism from what major depression is, right? So, which takes weeks to months to work. So it's a different biological pathway that we're affecting with SSRIs. If you use an antidepressant that doesn't have a serotonergic mechanism, it's not going to work.
Not going to work. So bupropion, not good. Yeah.
Right, exactly.
What's interesting is we know that an SSRI increases serotonin levels within hours, as you said, but for regular MDD, it takes weeks for it to work.
Right.
So that is fascinating, the difference
exactly.
here.
We talk about serotonin for major depression, but it really is downstream effects.
Yeah, exactly. What is the standard of care now for a woman who is not taking a psychiatric medicine, who comes to us with PMDD? Is the standard of care now intermittent dosing, or is it just put her on the SSRI every day?
Depends on the person.
Okay.
And let me say that about 50% of cases of PMDD are SSRI responsive. So about 50% don't respond to SSRI. So there's probably two different types of PMDD. And one, you really have to stabilize the hormonal changes. And the other, you can use the SSRI. Some women find it easier to take a medication every day. All right. And some women love the idea of just taking it when they need it. And so I usually leave it up to patient preference.
Yeah. Now, you brought up something extremely interesting. I also work in the ADHD space, and I have recently gone to some tremendous lectures on the effects on cognition of a woman's menstrual cycle and at menopause. And what people now in the ADHD world are talking about is exactly what you said, bumping up their ADHD medicine at certain times. That's something I don't think a lot of people think about, is the cognitive effects of these hormonal shifts.
Yeah, and there's definitely cognitive effects. So low estrogen states are not really great for a woman's brain.
Well said. Well said. Okay, well, that's extremely helpful. And then if we're talking about menopause, another clue to bipolar I have found is a woman who's had histories of depressions and gets a really bad one around menopause. Again, I'm not saying that is bipolar, but I have diagnosed 2 women in their 40s with that clue that prompted me to go back and be more careful in my history. And I uncovered what looked like hypomanias and depressions, and she was probably bipolar too, or these 2 women.
Mm-hmm.
Yeah.
Absolutely. So, and I will say that as someone who's managed bipolar disorder over the course of a couple decades for several patients, I've had women be absolutely rock solid stable for most of their adult lives on fairly low doses of mood stabilizing medications who absolutely had a really rough time during perimenopause, which is the time leading up to menopause.
Yeah, exactly. So let's talk about that. So how do we deal with menopausal mood symptoms and mood states?
So let's define menopause. So menopause is really only one day in a woman's life. It is when she has not had a menstrual period for 1 year. And prior to that, she's in perimenopause, which means around menopause. And after that one day, she's postmenopausal. Okay. And so perimenopause is the time leading up to menopause, during which hormonal fluctuations that were really regular become very irregular. And what a lot of women experience is, I had one woman describe it to me as, it's like I have PMS, but it's random now. And it's no longer just right before my period. It can be, right after my period for a few days. And that is because the hormonal fluctuations really start to get a bit out of control and can affect, mood symptoms. Perimenopause can last as long as 10 years, believe it or not. But it typically lasts a few years and can be accompanied by a lot of physical symptoms. Getting older, your skin changes, you get hot flashes, you don't sleep as well. And a lot lot of women notice cognitive symptoms or brain fog is
Yeah, I was
usually
just
what
going
they
to say
refer
my wife
to.
complained a lot of brain fog. That was
Yes,
a big issue.
exactly.
And irritability
Exactly.
and things like that too.
Right.
I did a study with desvenlafaxine for the vasomotor symptoms, but I remember vividly women coming back and telling me about some global improvement. It wasn't only the vasomotor symptoms. This was an SNRI, obviously.
Absolutely. And so the perimenopausal time period is another risky time period for the development of a major depressive episode. So even in women who didn't have major depression when they were younger can develop a major depressive episode for the first time in perimenopause. Now, what we know about that is that hormonal treatments can help the depressive symptoms. And once you've hit menopause, though, hormonal treatments do not help depressive symptoms.
Yes, that's an important point. I don't know that a lot of people realize that.
Yep,
Yeah.
exactly.
So we need to be aggressive at monitoring this and treating this. And certainly we know about the risks that have been described of hormonal therapy in a woman who's perimenopausal. But again, if we apply that dictum we said earlier about what's the risk of inadequately treating this,
correct.
it sounds like the benefits may outweigh the risks for a lot of women with hormonal therapy.
So it absolutely can. But again, I do think it's worth thinking carefully about that woman's individual risk. So we can't make a blanket statement here. In women with breast cancer or blood clotting issues, et cetera, hormonal treatments can be a big risk. But I think the movement right now is to be a little bit freer with hormone replacement therapy.
Yeah, we really pulled back there for a while. And, I also would take a careful family history, strong family history of cancer would also be something to take into account.
Yes.
Do you have recommendations on which antidepressants you would use during menopause? Is it SSRIs or?
During perimenopause, a lot of practitioners like the SNRIs.
I was going to say that they do work better for the vasomotor symptoms, I find.
They do. But SSRIs do work. So I think a lot of it's an individual approach for that particular woman.
Right. Yeah, maybe somebody who has more prominent vasomotor symptoms, that would tip me towards an SNRI, for instance.
Exactly.
For instance. Or again, knowing if a woman has responded well to a medicine in the past, say sertraline or fluoxetine, I'd be more likely to reinstitute that, I guess.
Exactly. Yeah. That's exactly what I do.
Okay, great. We're unfortunately starting to run out of time. I feel like this is so interesting. And again, it's an area where I certainly wasn't well trained in this, and it sounds like it's an area of active research. There's a lot of new information coming out. Could you maybe briefly talk about some of the research we talked about earlier? You had told me that you've identified actually a biomarker for postpartum depression, and certainly the holy grail in our field is more biomarkers. Agreed.
Yeah. So I'm pretty excited at this point. About 12 or 13 years ago, we it's a little bit of a long story, but we essentially identified epigenetic biomarkers that are associated with the later development of postpartum depression. So we can take blood in the third trimester and we can say you are at high risk and you are at low risk with about 80% accuracy. And I can tell you that, we're in talks with the FDA and we're doing a prospective validation study that I just started recruiting for a couple weeks ago. And I'm hopeful that we're going to have an FDA-approved test that will change the standard of care from a reactive one to a preventative one.
That would just be fantastic. I just think that would be incredible.
I'm pretty excited about it.
Yeah, well, I'm rooting for you, and I know everybody listening is rooting because, yes, if we could do that, boy, then I would institute the SSRI or the zuranolone right away, pretty much.
Exactly,
right?
Exactly. And you also, if you're taking blood in the third trimester and you identify someone who's at high risk, you have time to get them to a mental health professional, right? Once they're depressed, they're navigating the system, which has a 3 or 4 month waiting list, is really terrible. So
well, you just mentioned something really interesting. So this is the kind of thing that OBGYNs could do.
Absolutely.
In a woman who's not currently seeing a mental health professional. What a terrific idea. It could become standard of care for that.
Exactly.
I know you're probably involved in a lot of education, and I know that Sage Therapeutics, the company that makes zuranolone, is really involved with a lot of education towards OBGYNs in this space. And I suppose even pediatricians, again, they're the ones who see the moms after delivery.
Absolutely. And what I would love to see is that this becomes part of routine care for pregnant women. Yeah,
that it's just another thing you screen for, another thing you evaluate for and look for.
Absolutely.
Yeah.
And I mean, it's the most common complication of childbirth, right? We screen 99% of pregnancies for gestational diabetes, and that has a rate of about 5% or less, okay? And the most common complication of childbirth is perinatal depression, which has a rate of about 17%.
Oh, my goodness. I had no idea. That's amazing.
And so we with a blood test, we could easily screen every pregnancy.
Well, just knowing that, I mean, just getting the word out about that 17%, that's quite a high risk. And that means that we need to be a little more vigilant about this.
Oh, absolutely.
Wow, that puts it in context. Because, yeah, you're right. We always think about complications in very medical terms,
Absolutely. Yes, exactly. And if we're looking for, gestational diabetes, we should darn well be looking for perinatal depression.
Yeah, and eclampsia and preeclampsia, of course, all of that.
Yeah.
Great. Well, Jennifer, I really want to thank you for your time. This has been really helpful. I hope it's been helpful for our audience. I suspect it really has. And I do look forward to talking to you again as your research progresses. You've teased me a little bit about what you're up to here. And any final words you'd like to say for our audience about what we've talked about?
The one thing I will say is please don't be shy or scared of treatment during pregnancy and lactation. It's actually quite important for everybody involved.
Yeah. There is one last thing, though. I'm involved with Supernus. They have a medicine for ADHD, a non-stimulant. It's viloxazine extended release. They have just recently met the new FDA's guidelines for studying the medicine in lactation and found it to be only about a 1% relative dose that gets transmitted to the infant, which is considered relatively safe or relatively low risk. And I wonder if more medicines might be studied in that way so we could have a more accurate sense of how much of the medicine is being transmitted to the infant.
Yeah, well, we know for a lot of medications what the relative infant dose is, and that information is available. So there's a website called LactMed that you can look some of that up on. However, I encourage psychiatrists to not get obsessive about that. So, one common scenario is to have a woman take a medication and be well during pregnancy, and then her doctor will get exciting information from LactMed and then try to switch her to a different medication, which makes no sense because the babies are exposed to the first medication and you risk relapse, particularly in that vulnerable postpartum time period. So don't get obsessive, but that is a good resource.
Well, that's a great point for us to end on, which is coming back full circle to what we said earlier, which is please don't forget about the risk of inadequately treating the illness or of risking relapse, because that is so risky for both the mom and the baby. Thank you. That's a terrific public health message we've delivered. I want to thank you all for listening. I hope you found this informative and interesting. And for more information, you can find all of our podcasts anywhere you get podcasts under NEI Psychopharm, or you can search my name, because I'm the moderator and the host. And please go to our website, NEIglobal.com, for more information about not just our podcast, but our other educational resources, our live meetings, our virtual meetings. And finally, Jennifer, again, I want to thank you so much.
Thank you. I really enjoyed this.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.